Okay, so today I am talking about the low back pain. As last day also we talked about the transforaminal epidural and the facet joint. Facet joint mainly causes the localized pain, and when it is a disc prolapse, it mainly causes the radicular type of pain, which is more, more painful in the legs. Patient will come to you and say that my leg is more painful than back. But when it is a facet joint pain, patient will come that my back is more painful than leg, because ultimately it depends on the pain generator. What is causing the pain? So in a radicular pain, most of the time it is the nerve which causes causing the pain. So when a back pain patient comes, there are two things should come to our mind. One is pain generator and one is background phenomena. So where from pain is coming and what is the reason why that structure has suddenly become a pain generator. So we know that what are the structures, whatever they are in our body, that is the pain generator. That can be become the pain generator, either disc, vertebra, nerve, cord, joints and muscles, ligaments, so all these things. But we are talking about the most important and common pain generators and the related interventions. So today I will talk about SI joint arthropathy. So SI joint pain also, SI joint is also a common pain generator. So you can see when we see a X-ray, we want to see the margins of the bony margins of a joint, whether that looks normal or not. So margin can be eroded, can have osteophytes, or it has some that what should I say? So erosion and osteophytes are mainly we see in X-ray in the margins. Okay, sometimes the margins are fused margins around the some sclerosis around the margin. Sclerosis means fat deposition. So fat deposition around the margins is somehow it is a symptom of degeneration, sign of degeneration, and that is expected. Sclerosis doesn't mean that that joint is painful. Even the erosion also doesn't mean that that joint will be painful, but this is confirmed that this joint has arthropathy. This is not a normal joint. So here you can see the normal margins. The margins are all normal, no sclerosis, and margins are there is no erosion, no osteophyte. So this is grade 0. And then comes grade 1, 2, 3, 4. So gradually these this erosions will increase. Here you can see in grade 3 it is severe erosion, and grade 4 means ankylosis. There is no joint space. So we will not go for any intervention if there is ankylosis or there is it is a normal joint. In other grade 1, 2, 3, if we think that this is the SI joint is the pain generator, we will go for intervention. So what happens? So most of the time SI joint pain is a non-radiating type of pain. It is localized pain and localized paramedian pain. It is not in midline. It is just over the SI joint. But remember, and it can have some referred component, not radicular component. Two types of there is a difference between radicular pain and referred pain. Radicular means it is following a dermatomal pattern, a specific nerve dermatome, the pain is going down, like say L5 radiculopathy or L4 radiculopathy. In L5 radiculopathy, the great toe is affected but not the other toes. So it is a typical dermatomal pattern. But referred pain doesn't have a typical dermatomal pattern. Somebody has SI joint pain, he can have the back of the thigh pain or some amount of knee pain or calf pain, and there is no continuity. So that is called referred pain. So here location is pinpoint location, and it can refer to groin and hip or anterior thigh. So these are common referral pattern. And one thing, always in SI joint arthropathy, just exclude the tuberculosis in our country, and inflammatory back pain if it is a spondyloarthritis. So if spondyloarthritis is the background phenomena, then no matter how many times you treat the SI joint arthritis, immediately patient will respond, but it will recur. So in SI joint arthritis, these two background phenomena should be searched for, and if it is there, then you have to treat them also as well. So, and one important thing, if the background phenomena is inflammatory, then patient will come saying that I have this gluteal pain. Mainly it is called as buttock pain, unilateral buttock pain, and it is changes side. Sometimes right, and after one episode is in right side, one episode is in left side, like that. But rest will increase the pain. Rest increases pain, and increased pain in the morning time. The whole night's rest, it increases the pain. So that is a inflammatory arthritis type. And SI joint test. So what do we do in tests? So actually, a test means you actually compress the joint. You want to increase the tensions in the joint, and you move the joint. So there are multiple tests: destruction test, thigh thrust test, sacral test, Glensen's test, compression test. Faber test is our commonly done test. So it stretches the SI joint. Of course, Faber test is not only stretches the SI joint, it also stretches the hip joint. So Faber test is positive in both the things, SI joint and hip joints. So if SI joint is positive, then only you will think that, okay, I have to think that which one is painful. Of course, in SI joint, local pain is posteriorly, and hip joint, it is in the groin. And so many tests are here because no one test is acceptable or completely you can believe that, okay, this test is final and I can diagnose SI joint arthropathy. Not that. So you have to go for 2-3 tests, and if it is positive, then chances of SI joint arthropathy is more. Now treatment. So as I told you, treatment is also in two headings. One is local treatment, local area treatment, and second is background phenomena treatment. So local area treatment means your injection should be either inside the joint to combat the inflammation, or you target the nerves and you cut down the nerve supply. If there is no inflammation as such, but still there is so much of destruction of the joint that whenever patient moves, there is a pain. So in those cases, we will cut the nerve supply. So in this course, of course, we will talk about the intra-articular steroid injection. So intra-articular intervention we will talk about, and that is the most used intervention and most successful also. So here, see one thing. This is a SI joint is a three-dimensional structure, but the X-ray will give you a two-dimensional picture. Just a minute. Just a minute. Huh? Okay, so as I was telling that just see my in and make spotlight for everyone. Okay, so what I was telling that SI joint ultimately it is a three-dimensional structure, and we are seeing in the X-ray, when we are seeing that, we are seeing a two-dimensional structure. So what is important here? By seeing a SI joint, you must understand that what actually you are seeing. So you see, this is the sacroiliac joint. So this is the ilium part, hip bone and ilium part, and this is the sacrum part. Okay, so now we have to go inside this joint, but as you can see, I can put my finger inside it. That means what? There is a major portion, big portion of ilium which is actually not forming a joint. Okay, so joint is formed by only a small part, only this lower part, and that also this much part is a joint. Other part is not forming a joint. Other part is actually the ligamentous structure. This area there is ligamentous structure. So when we go for intervention, we always target the lower one third of the joint. Okay, first thing. Second thing is, this is a diarthrodial joint. Diarthrodial means what? You can think that in middle part, this is the sacrum, and in this side ilium has come. Okay, but ilium has not come like this. Ilium has come like this. So this part is not forming a joint, and only in this part a joint is formed. But this diarthrodial uh, uh, type of joint, what is the thing we can understand? That one joint line is medial and one joint line is lateral. So when you will be seeing the joint, you will see a joint line of round like this. Okay, so the posterior joint line is medial. You can see this is summary line, that posterior joint line is medial, and anterior joint line, which is there, these joint lines are anterior joint lines. These are anterior joint lines. So anterior joint line is actually lateral. Okay, so anterior joint line is lateral because you can see that this bone is coming up to this much. So here also one joint line is there, and here also one joint line is there. So posterior joint line is medial, anterior joint line is lateral. Now how much lateral and how much medial, it differs from patient to patient. From medial to lateral, it may be 2 centimeter gap, or maybe 1 centimeter gap, or maybe even less. So what is the, so with this gap also, or these two lines, how our procedure changes? Our procedure changes because our target is only posterior joint line. You patient is lying on the couch in a prone position. You have to go inside the joint. There is no way that you can go through the anterior joint line. It is not possible. You have to go through the posterior joint line. So in a three-dimensional picture, but when you are seeing a two-dimensional picture, then entering first you have identified that this is the posterior joint line. So medial joint line is posterior joint line, and lower one third is my target. That much you have understood. But direction of the joint, in which side the joint is opening in this side, because this bone is going, and I mean, like, it is covering some part of the sacrum. Ilium is covering some part of the sacrum. So door is open like this, in this side. Okay, door is open like this side. So what you have to do, you cannot see the joint directly from above. You have to see from this side, uh, like this side. Okay, in this way you have to see. So you see means what? The x-ray machine, the receiver, that will see. So we will do a contralateral oblique. Okay, so most of the lumbar cases we did ipsilateral oblique, but here we will move the x-ray machine to opposite side, so that it can see the opening of the joint. Okay, because you can see, if say this is right side, opening is in the from the left side. Okay, and the opposite one, you can see this is the SI joint is left, but opening is from the right side. So that is the main basis of contralateral oblique direction. Okay, rest of the thing you will understand while I will do the procedure. But then This is the initial part. Okay. Is that? So this one. Okay. So we can understand. So you can see my slide, isn't it? Somebody can say actually. So I think I'm audible, isn't it? Okay. Somebody can say, otherwise I will not understand.
Audible,
Right.
sir.
Yeah, yeah, audible,
Okay,
yes.
okay, okay. Okay. So just now what I showed you, so you can try to understand here. So this is sacrum and this is ilium. This is ilium. So you try to understand that ilium is covering sacrum from the posterior side. Okay. Ilium is covering the sacrum from posterior side. So where is the sacrum then? So what is the sacral border? Sacrum is anteriorly placed. Okay. Sacrum is anteriorly placed. So, and posteriorly, this is the ilium. But do you think that whole thing is joint? As I said, that this area, say, this much is the joint. Okay. Say, this much is the joint area. Rest of the area, the upper part, rest of the upper part area is actually hanging. This part is hanging over the sacrum, as I just showed you. So this is the area. So now let us see if I remove the drawing. So you can see when you will so in this side it is more clear. So here you see this is the joint part. Okay, only this. So see clearly, there is a line. Actually, there also, here also line should have been there, but it is not there because it is somewhere a bit angulated picture. That's why. Okay. So this side, when we will do the joint, so this is the joint area. This part is covering the sacrum. This part of ilium is covering the sacrum, but it is hanging. Okay. Sacral margin is this one. Okay. So now, and not sacral, iliac bone margin is this one, and sacral margin is this one. Sacral margin is this one. So for our target is only this much. We know that this much is a joint. Okay. So which one is posterior line and which one is anterior? Somebody tell me, green line or red line. Which one you can access? Then I will understand that you understand.
Green line.
Green line.
Red line.
Yes. Yes, green line. Because from posterior side, bone is covering. So this is the green line. So if we, so first thing, medial line, this green line is our target. Okay. Then comes the lower 1/3 or lower half, you can say, is our target. Because our upper part actually is many a times it is fibrosed. So this is our target. So remember the summary line, in a true AP view, the medial line and lower 1/3 is our target. Okay, true AP view. Here this picture is showing so bad SI joint. You can see not grade ankylosis has not occurred, but otherwise grade 4. So this is ankylosis. This is also so bad SI joint. Okay, upper one is not being seen, but this side is fusion, this side looks normal. Okay, so when you give SI joint injection, anything may come. Okay, okay. Here also you see the same thing. So this side is the posterior joint line, this is anterior joint line, and whole sacrum is covering a bit more area. Sacrum is covering a bit, not sacrum, ilium is covering a more area of sacrum, but these are not forming the joint. This is hanging over the bone. So our target is medial line and lower one third. Okay. Here you can see, as I told you, when we will see from one side, like contralateral oblique, then we will be able to see the joint in one line. Of course, it is not always true, because this is not something like a parallel wall. It is not a parallel wall. It is also bumpy. Some area is bumpy, some area is different. So this is always not possible that you will be able to make the whole portion, like it is not always possible that you will try to make the whole two sides in one line. Though I am saying that it is a door, but it is not a plain wall. It is not like our door wall. So it is possible that some part is overlapping, but some part is not overlapping. Again, say this much. So you can see that middle part is not overlapping, but then upper part is overlapping. So this thing can happen, but we want to overlap it so that we can enter through the posterior joint line. That's it. Somebody is making sound. Mute. Okay. So you can see in this way, then we will put the needle. So here you can see this needle placement type is called tunnel view approach. It is like a dot only. Okay, this is, so most of the procedures are tunnel view approach, and after that we will inject the contrast and we will see how the contrast spreads. Contrast spreading you will see in oblique view also, in AP view also, and possibly in lateral view also. So this is a very nice contrast spread, but every time this clean, very nice contrast spread may not come. Why? Because there may be torn capsule. So when you will give the contrast, it may spread this side or that side. Okay, here. So this is the part of lower part of the capsule. So some contrast is coming in this side also, but it has spread beyond the joint line. So here it is most of the spread is in the joint. So in AP view we can see this type of spread, this type of nice spread. You can see the whole joint, but this is the good joint where there is no tear. Okay, in lateral view you can see the spread like this. Okay, so as I told you, we can do intervention, intra-articular intervention, and if we choose for just ablation of the nerves, then we will ablate the nerves which is supplying the sacroiliac joint. So all lateral branches of sacrum, S1, S2, S3, and of course L5 also. So those branches we can denervate by radio frequency or cryo. There are different methods, different also there. So let us go. SI joint, already I have told you the theoretical part. I will demonstrate after that. At present, I show you the S1 and caudal, S1 transforaminal and caudal. So we have understood that it is the degeneration which causes, first it causes that disc degeneration can The degeneration process which comes with age, it affects the disc first. So the disc height can decrease and quality of disc also goes down. Quality of disc goes down means it becomes dehydrated. Okay, just a minute. Okay, so it becomes dehydrated and height of the disc decreases. But this degeneration process can affect all other parts. So what are the other parts? Like bones, vertebral body, osteophytes can form. Okay, posterior to the spinal cord, where there is ligamentum flavum between the laminas, this ligamentum flavum can become hypertrophied and disc can protrude also. So, and these are all degenerative changes which increases with time, and ultimately there can be a pars fracture. Pars fracture causes listhesis. So vertebra can slip one over another. Ultimately, what is the result? Result is canal stenosis. The spinal cord which is going through the spinal canal, it will get stenosed. So what is the result ultimately? When the spinal cord will get stenosed, there is symptom of neurogenic claudication. What is neurogenic claudication? Patient can walk some distance, but again patient has to sit. So after sitting for some time, again patient can walk for some distance. This distance which he can walk after taking rest, this is called neurogenic claudication distance. And gradually, with more and more pressure, with more and more stenosis, this distance decreases. Many a times patient will come to your clinic saying that earlier he could walk say 1 kilometer, now it is only 200 meter. Gradually it decreases 500 meter, 200 meter, like this. So neural ischemia and defective nerve conduction can occur. So that is the gross spondylosis, ultimately lumbar canal stenosis, and this type of symptom can occur. So what is the treatment? Here, as I told you, this is not about one root. This is about the whole degeneration area. Where it is not about the only one root or only one structure. It is about the degenerated facet joint, hypertrophied this one ligamentum flavum, and even small amount of listhesis, all these things. So in these cases comes the here is the role of epidural steroid injection. You can see there are multiple studies actually. So efficacy of epidural injection in treatment of lumbar central spinous stenosis. So here it is a systematic review, and there is efficacy is there. So it may be level 2, but I mean, we also do regularly this thing in clinical practice and we get good result. These patients, of course, one can say that they should go for surgery. You advise for surgery, of course. These are structural abnormality, and with one simple intervention, you cannot remove the structural abnormality. So you give the option of surgery, and every time patient may not be ready for surgery, and patient may not be fit for surgery. For in those cases where it is a gross degeneration of the full lower lumbar area, and you cannot, I mean, there is no meaning of going for one structure intervention, either facet or say this one radicular pin, then we choose for caudal epidural. So in caudal epidural, so you know caudal epidural very well. Just a minute. So we know caudal epidural, you know caudal epidural very well. Ultimately, it is a epidural only. Ultimately, we have to go to the epidural space only. So under X-ray, we have to see the two sacral plates. Okay, this is the posterior sacral plate.
Excuse me, sir. Sir.
Yes.
Chinmay, sir.
Yes, yes.
Sir, I want to ask one thing, that what is the exact indication of this caudal epidural? Whether stenosis of all levels or only specific L5, L4 level?
No. All lumbar levels. All lumbar levels. Mainly lower lumbar levels, because if it is the stenosis at the L1, L2, then Of course, this will not work, but then 3, 4, 5, S1, these areas. And that is the commonest area. 99% will come with this only.
So if there is a stenosis and there is a radicular pain, then you can give transforaminal epidural or caudal epidural.
Yes. This is completely based on clinical symptom. If there is a anatomical, you can see that MRI showing stenosis. So anatomical deformity is stenosis. Which patient is coming to you with L5 radicular pain? Then you will go with the patient symptom and you will give transforaminal epidural. We are not treating the MRI, not making the MRI clean. So we will go with the patient symptom. But if patient says that I walk for some time, then I have to sit, then again I walk, someday right side pain, someday left side pain, or both side pain. So you can understand clearly that it is not a single pain generator. So in those cases, you will go for caudal epidural injection. Okay.
So can we do the both procedures simultaneously, or
There is no need. There is no need. Why we will do both procedures simultaneously? So that is what I am saying. Then this is the epidural space. If you go backside or somebody is talking so much.
I'm
Yeah. So thing is that when we are going in caudal epidural, so this whole area is epidural space. It doesn't matter you go through the caudal entry or from the transforaminal lateral entry. Of course, not in this area, in this area. So transforaminal lateral entry or from the posterior side interlaminar entry. Interlaminar entry we do not prefer because it there is a waste of drug. You are giving 80 mg and 10 mg is going to the site of disease. Okay, disease site is this one. Okay, so there is a waste of drug. That's why we will always go for transforaminal wherever possible. In a caudal epidural, it is not possible because there are multiple sites. So we will give, we are going for caudal epidural. But here, ultimately you understand these are all epidural space and they are all connected. So there is no meaning that I am giving caudal epidural also and then transforaminal also. These are all connected. Same space. So in X-ray,
thank you, sir.
we will, yeah. In X-ray, we will see the posterior sacral plate and anterior sacral plate. Anterior sacral plate is nothing but the posterior vertebral, sacral vertebral body. And our needle will come simply it is a epidural space. It will come in the epidural space. Here, remember the most common thing what happens in epidural. If nowadays we can see it very clearly, but earlier people used to give blind epidural. Here, when you are coming from the through the skin, just above the sacral bone, okay, just above the sacral bone, there is also a feeling of loss of resistance. This upper part is muscle, and between the muscle and bone, there is a area where you feel the clear loss of resistance. But then that is not the target area, and you have to come in the epidural space. How much you can enter? You can go up to the lower border of S2 because we do not want to puncture the dural sac. We have to remain in the else epidural space. So lower border of S2 is your highest target and always in the midline. Okay, we'll go a bit fast, otherwise. Okay, so intervention theory, technical aspects and demonstration. So I think you remember the common steps. Always step one is target level and site. Okay, in which you are going. Second thing is patient right, screen right. This is the second step. For true epiview, there are 3 steps. Another 3, 4, 5. So what is 3 step? That is the pedicle and spinous process distance remains same. Though it is more applicable for the lower lumbar area, But when you are making a clean AP view, then while seeing sacrum also, you are seeing the L5 also. I mean, that is because this area is accessible in the same view. So true AP view, step 3 is, as I told, that pedicle to spinous process distance remains same. Then comes step 5. Okay. Now step 4, that is the making the end plate parallel. Making the end plate was 2 lines when you see the first image, so making the end plate parallel. And then step 5 is seeing the Scotty dog, making a Scotty dog by oblique view. Okay, so these are common. And then Allara principle means radiation you should use as low as required, as low as possible. Some common consideration for before any intervention, diagnostic or therapeutic, you are doing, you ask yourself and decide accordingly. Need fluoro. This is not a blind technique. We do not remember any degree or anything in that way, any measurement as such. We are seeing under X-ray, and that is our measurement. We do not have to remember anything like that. End needle position in different views for all intervention. You must see AP, lateral, oblique. These are in all the 3 views. End needle position you must see. Use of contrast, typical or non-typical, or any dangerous pattern. So remember, when I am giving a contrast, you must try to see a typical pattern. If it is not typical, then also you will not proceed with the procedure. And if it is dangerous, then of course you will abandon the procedure or you will not do the procedure. So it is not that always you have to wait for the dangerous pattern. It has to be typical also. Contrast, non-ionic, water soluble, so that we are using Omnipaque type of iohexol under live fluoro. Many times when it is a around vessels, if you have small confusion also, go under live fluoro. Actually this advice is recommendation is give the contrast under live fluoro. But sometimes of course clinically we also want to live and we don't want to get that much of radiation, so we do not use live fluoro. But if you have any sort of confusion that I am not giving inside the vessel, then always give contrast under live fluoro. Right. So other part, consent part, post procedure advice, this thing you should give. Always never practice in this way that surgeon has told that please go for an intervention, give caudal epidural, and you given caudal epidural and your work is done. Do not do like that. Patient should know you, and after procedure it is your responsibility to follow up the patient, that what happened after the procedure. So post procedure advice and all is yours. Facility for tackling side effects should be there. You should not take these procedures very lightly. Even with trigger point injection, my case even got vagovagal attack and became unconscious. So needle size and type also you should decide before the procedure. Drugs, preservative free local anesthetic, depot corticosteroid we are using. Okay. So this part I will not talk about. Scotty dog already you know. So just to show you once, so this much you have understood that this is the pedicle and this is the eye of the Scotty dog, and this is the ear. So this is superior articular process of lower vertebra. This is front leg. This is the inferior articular process of upper vertebra. This neck part is pars intra-articularis. This body is lamina, and transverse process is the nose of the dog. This is a tunnel view approach. So this is also, there is no need. This is oblique view, AP view, lateral view. We will always see, so that where the end point of the needle is. So this is lumbar transforaminal injection. But remember, here also we are going to the epidural space. So if we come down here, lumbar transforaminal injection after giving contrast, see. Here you can see this is a normal X-ray. Small part is going inside the vessel. This is going inside the vessel. How do you understand that this is a clear line of contrast can tell you that it is maybe it is going inside the vessel. So same picture is under the digital subtraction angiography. So this procedure was being done in a DSA suit, actually in angiography suit. That's why they could take. So the thing is that and for a small amount of doubt also, you should not proceed with the procedure, because once you have not given the drug, control is in your hand. But once you have given, then if it is your fate that if something doesn't happen, you are lucky, and if something happens, then gone. So this is also intravascular in a transforaminal. So let us see the S1 transforaminal. So as I told you that ultimately we are going in the epidural space. So when we were giving from the lateral side in the lumbar area, we are going in the lateral side. But in the sacrum, it is the posterior side, but going in the epidural space only. So what is the difference here? Here difference is again the same thing. We are seeing a three-dimensional structure in a two-dimensional way. So what is the thing? I just draw it here. Okay, say this is, I am drawing a sacrum. Okay, but sacrum is not like that. So remember, this is a parallel. This is, say, hypothetically, so if sacrum would have been like this, a straight line. So this is the posterior foramen and this is the anterior foramen. Posterior foramen, anterior foramen. So say this is S1 and posterior, it is S1 only, S1 anterior, and this is S2 posterior, S2 anterior. So what will happen? You will see, your fluoroscope will see from here, and you will just enter the needle in a 90-degree position, and it will come through the posterior foramen and come out in the anterior foramen. I mean, it can come out. If you don't enter much, then it will remain here in the epidural space. Okay, this is clear. So but then in true life, sacrum is not like that. So what is the sacrum shape? Sacrum shape is like this. So here what will happen? Here posterior S1 foramen is here and anterior foramen is here. Posterior S1 S2 foramen is here, but anterior S2 foramen is here. So if you see a three-dimensional structure in a two-dimensional way, so what will happen? There will be great confusion that which one is posterior and which one is anterior. So what we have to do? We have to see this, say S1, through S1 we are going. So we have to make these two S1 in a same line. So we have to see from here, okay? So if we need to see from here, then what is the difference? Difference is you have done you have given a head tilt to the receiver, X-ray receiver. But then lower sacral foramens are actually, you can see the opposite way. Okay, maybe this is the S5, which is not needed actually, but just I am showing you, telling you about the concept. So this will be S5. So to make this in one line, your X-ray receiver will go in the opposite way. It is a caudal tilt. So just remember, when we are seeing, say this is a AP view, so we are seeing two types of foramen here. In two-dimensional view, we are seeing three-dimensional structure. So two types of foramen. One foramen is very nicely seen, very nicely seen. But problem is, whatever seen nicely is not of very great importance. So this is S1, this is also S1, this is S2, this is S2, but they are anterior foramen. So we do not have any use of them because we cannot go through anterior side. So you see the left side picture, you will understand very nicely. You can see the anterior foramens. So where are the posterior foramens? So these are the posterior foramens. Okay, so you can see posterior foramens are a bit above. So here also you can see here S2 is not clearly seen, but S1 is seen. So this is the posterior foramen and this is the anterior foramen. Okay, here so this is epiview. So how can you make both the foramens together? So you have to go a bit cranial tilt so that these foramen they come in the same line, and they this side, I mean, it will gradually come down, and ultimately this fish mouth appearance will come. So this fish mouth appearance is nothing but the overlapped area. Okay, so here it is already small amount of overlapped area is there. So we can go like a tunnel view approach here. So we will enter in the epidural space. Okay, so you can tell me, I mean, you can ask me that why this thing is required. S1 foramen is nicely seen, so why this tunnel view and all? We can go here also, then also here inside the foramen. So problem is that here it is the manicuine, but in a normal patient, this complete thing cannot be seen. There you will in a normal patient you will see the anterior foramen, and posterior foramen you will not be able to see. Here also something can be seen, but you see you cannot make out S2 and all. Okay, so what happens? This is actually manicuine picture, and this is a normal patient. Okay, so you can understand that S2 foramen you cannot see. So what will happen? So that's why when the fish mouth appears, it becomes clearly visible. Then you understand that where is S1 and where is S2. Okay, so just few pictures and then I will demonstrate. So here you can see the same thing. Here all okay, this one is S1 foramen posterior, but this is anterior foramen. These are all anterior foramen. So this is a three-dimensional structure, I mean 3D reconstruction. So here caudal canal is also shown. So here you see this is the caudal canal, and this is the unfused lamina of S3. Remember, from S3 only caudal canal starts, lower half of S3. S4 and S5 is totally unfused. So that is the entry point of epidural space. So here, as I said, that one foramen is a bit caudal and one is cranial. So you go cranially, tilt headwise, you will see. So here you can see both the needle in L5 also and S1 also. So this is L5 transforaminal. This is S1 transforaminal. This is L5 transforaminal, not caudal. Okay, whenever you give caudal, you do not need any transforaminal. Here two roots are blocked. Okay. So after giving contrasts, the contrast should spread in the epidural space upward. So it should spread like this. So anywhere, this is a caudal placement of needle, and this is a S1 through S1 placement of needle. In both the cases, you can see the drug is going through intravascular. So this is a dangerous type of spread of drug. Okay, just a minute. So this is the I mean vascular spread. This is the vascular spread. Hmm. Okay, so this is the vascular spread you can see, and if I go more, so this is a say suboptimal spread of contrast, and actually we wanted that drug should go in the epidural space through the dorsal foramen, but drug is coming out. So this is not a acceptable drug spread, contrast spread, because first you give contrast and then you understand if you give drug where it will go. So caudal epidural, as I said, it should not go more than lower level of S2, and it should be in midline. And common error, of course, superficial to sacrum also people puts, but not under X-ray, of course. So, and after giving sacrum, you give contrast, and it says us many things that say this patient, in this patient. So, though this needle position is a bit one-sided, and here you can see there is so much filling defect. Filling defect means the maybe this is earlier operated multiple times, or this is a post-laminectomy case. So in those cases there is fibrosis. So if you give contrast, then also you know that spread has occurred, which area drug has gone. So in that case you can anticipate that patient will get better or not. Okay, here the spread drug is going, a lot of drug is going anteriorly, leaking out anteriorly and not going upper side. Cotton ball appearance means this is above the sacrum, just I mean it's a wrong place, not in the epidural space. Vascular spread, this is, you can see that this is like a myelogram. Your drug, of course this is a interlaminar, so I will not discuss, but then still this is a subdural spread, only small amount of drugs and it goes so high. So here also it is a caudal epidural. So this is a spread in one side. Drug has gone in one side, but not the other side. So patient's pain, I mean, patient will not get that much of benefit. Here you can see very nice feeling that in lateral view, you can see that your contrast has gone in the anterior epidural space and also in the posterior epidural space. So our target is to spread the drug in the anterior epidural space. So these are all post-laminectomy cases. So here you can see that a lot of drug has leaked through the anterior sacral foramen and very less drug has gone up. So you cannot expect that if patient has pain of upper lumbar area also, he will get relief. Patient cannot get relief in that case. Okay, so now I will go for the demonstration. So first we will go for the SI joint intervention. Okay. In the meantime, if anyone wants to ask any question, please ask. Everybody can see the picture.
Yeah, it's visible.
Okay.
You log this preview.
Oh, yes. Yes. Okay. So now this is a clear AP view. Okay, this is a clear AP view. We can see what we can see here. Though we are more interested in sacrum and ilium, but still we are in AP view or not, we can see this is the spinous process and these are the pedicles. So it should look like spinous process to pedicle distance should be same. So you are in the AP view. Remember what I am saying is a normal where there is normal alignment of the spine. If somebody has congenital scoliosis, don't try to follow that. Okay, so here let us see where we can find the sacrum and where is the ilium. So this is the ilium. This is the ilium. Okay, now where is the sacrum? So this is the sacrum. So now where is the SI joint? There are two joint lines, pear-shaped joint lines in this area. Okay, so now if I remove the drawing, then you can see one joint line is this one actually. Whole joint is not that clearly seen, but still you can understand that there are two joint lines. One is coming like this and one is going like this. So you can understand that the only joint line is this much only. Okay, this is the area of joint. Other part is bone hanging over each other. So our target is medial joint line, which is posterior. Posterior joint line. So medial joint line and lower 1/3. So we will go for injection in this area. So what we will do for, say, if we see this side, say left side. So this say this is this mannequin. So think this is head. One person is lying prone position. This is head and this is the hip side. Okay, so this side is left side and this side is right side. So we want to see the left SI joint. Okay, so this, to see the left SI joint, our this fluoroscope, the receiver has to go in the right side. So now we are moving the fluoroscope and let's see both the, so gradually it is coming, both the lines are coming together. Okay, see. Let's see. Okay, see, both the lines have come together and you can see this small part. I mean, as I told you that it is not that a lot of part will come and overlap each other. It is not possible because it is not a clean, it is a parallel, not a very plain structure like a wall. So some part is going like this, some part is like this. So we want to find out some area which is overlapping. Here, this area, small area, is actually overlapped. How we know? See the white color. See, color is much more whiter than other areas. So this is the area where we can go for intervention. So let me put the needle here. Okay, shoot. Okay, I am on the line, but I have to go a bit down. Shoot. Okay, so more or less I am I have to go at the tip only. Shoot. So you can see that this looks like a nearly, shoot. Okay, so this has become so tunneled that you cannot see even that where it is gone. So I will make it a bit less tunneled so that we can, okay, shoot. Okay, Shoot. Shoot. Wait. Okay, shoot. So anyway, I have gone a bit up, but wait, I will go down only. Okay, shoot. I'm going inside the joint multiple times, but I wanted to go a bit down. So take a shoot. Actually, this is many queens, so you cannot. There are so much cotton and all. Shoot. So I am inside the joint. Okay. How do I understand that I am inside the joint or not? Let's see in AP view. I will be in the medial joint line. Of course, if you go a bit more, then you may come in up to the, you may cross the medial joint line. AP, complete. Yeah. Shoot. না অতটা না কম কর AP. That's it. Okay, shoot. Okay, so you see that I am in the medial joint line clearly. Of course, it is a diarthrodial joint. If I enter more, I will go a bit, I will cross the medial joint line. Shoot. You see, I'm gradually passing through the joint. Shoot. Like that. So I can, pass through the joint also, but that is not needed. As soon as you are inside the joint and you will feel a loss of resistance, first give contrast and then give drag. Okay. And main thing is we want a typical distribution and we do not accept any type of intravascular or any type of dangerous distribution. So any confusion here? Anybody, if anybody has any
Sir,
confusion, yeah, tell me.
Sir, what is the volume of drug? Volume of drug.
Oh, volume is 5 ml. 5 ml volume, and drug in one joint you can give 40 mg of dipomedrol. 40 mg dipomedrol in 5 ml. Sometimes we give a bit less also, like 30 mg is enough. Okay.
Is your local anesthetic?
Yes, with local anesthetic, because why we use local anesthetic? Local anesthetic gives immediate relief, and you also become sure that your suspected pain generator is correct. That is the main use of local anesthetic in this type of cases. Okay.
So, what are the complications that can we face while doing procedure? Complications?
Complication, just now I showed you, no, that mainly it is the intravascular injection. Yeah, nothing else. Nothing. Other no important thing is there. Yes, if you do cause an infection, then nobody can help you. That is one thing. Infection and all that is can happen. Otherwise, nothing can happen. And as I
pain
said,
relief is for how much duration? Pain relief is for how much duration after the procedure?
See, I told you two things. If patient doesn't have a what should I say? It depends on the reason of pain generator, background phenomena. For pain generator treatment, as a pain generator treatment, if it is an acute inflammation, say some patient acute exacerbation of spondyloarthritis, you have given, it will give very nice relief till another exacerbation. So if you manage the spondyloarthritis, ankylosing spondylitis and all well, so it will not come back. But after 15 days only, again, drug did not work, his systemic drug is not working, and his ESR CRP is very high, then it will come back. But then local SI joint intervention is advised by all criteria, ACR, American College of Rheumatology, and all. In all arthritis also, local steroid in SI joint arthritis is advised, and it gives the best result. Yeah. So any other question? Otherwise, I will go for S1. S1 transforaminal. So let us take the same picture only. Here in AP view, we can see which is the best foramen. These foramens are very nicely seen. These foramens are very nicely seen. But these are of no use because these are anterior foramens. Okay, so this is S1 anterior foramen, this is S2 anterior foramen. So where are the posterior foramens? Let's see where are the posterior foramen. So this is the posterior foramen. It looks like this is the posterior foramen. Another foramen I can see here. This side I cannot see clearly, but it looks like in this area maybe. So mainly S1 foramen I can see here. The S1 foramen I can see clearly. Okay, but you think in a normal patient, this picture is on mannequin, so you can see very clearly. In a normal patient, you will see only this much. Okay, S1 foramen you can see which is an anterior foramen. So now you want to see the posterior foramen. You can expect that this is the area where the foramen should be. So what we will do, we will go for head tilt now towards the head, and fish mouth should come. Both the foramen should overlap each other. Gradually coming. Okay, so this distance is decreasing. So let's see it decreases more or not. Go. So it has decreased even more. So it has decreased, but not okay. Go a bit more. Actually, this much of tilt is not needed in a normal patient, but as it is a mannequin and the angulation is made by us, so that is the reason. Okay, so you can see this is the fish mouth. This is the fish mouth. So this fish mouth you can see in a normal patient also very nicely. Okay. So anterior foramen and fish mouth you can see. Posterior foramen, if you are lucky, then only you can see. Otherwise, you have to make it visible. Okay, shoot. Hmm. 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 Oh. Hmm. Okay, so just at the tip of the forceps, I can go and I will make this procedure also a tunnel view approach. Shoot. Going a bit more materially. So, so this is more or less going in tunnel view. Oh, this has gone a bit up immediately. It's happening. Okay, sure. Okay, so I have entered, though not through the fish mouth, just above the fish mouth. Why? Because this fish mouth is formed by the margin of the both foramen. So this is the anterior foramen, and the upper one, which is the posterior foramen. So that is giving me the entry, because this total area is posterior foramen. I am entering in the posterior foramen. So this is the fish mouth, but this total part is a foramen. So I have entered in the sacral through S1 foramen. I am in the epidural space. Let's see. Lateral. So AP view, just see once AP view. No, shoot, but AP view. So AP view without the tilt. So now it will not be in tunnel view. Oh, what has happened? So Now you can see that it is through the S1 posterior foramen, which is above the anterior foramen. So it is going through that. And now I will see lateral view. So where it should be between the two sacral plates. Between the two sacral plates, it should be in the epidural space. We are not and we have not entered through epidural window, caudal window, but the ultimately it should reach in the same plane. Okay, so it is in the epidural space. একটু ক্লিন করলে ভালো ছিল, একটু ওইদিকটা উল্টো নেই। sure. It's okay. So yeah, আগের মতোই ভালো. So it is in the epidural space only. So this picture is not a bit tilted. That's why the epidural, we should. It's okay. Hey, somebody is asking anything? Please tell me. No, I think nobody is asking. They are talking within themselves. Okay, so shoot once. So this is the right area. I mean, if you see in a very nicely your true lateral view, then you can see that this is the posterior sacral plate, this is the anterior sacral plate, and your needle should be in between. So this is the complete epidural space only. Okay. And okay, here just remember, sometimes it can happen. Sometimes I mean, total depth, in this total depth, you are in the epidural space. As soon as you go in the epidural space, you can understand, and there's loss of resistance, and when you give contrast, it will spread. But for that, these lateral view should be a true lateral view. Otherwise, if it is tilted, then it can happen that needle tip is in the epidural space, but you are seeing it here, up to here, or you can see up to here, whereas it has entered in the actual plane. So always you should check in the true lateral view of the sacrum. Okay. And how you will understand the true lateral view? You will understand by seeing a clear white line in this. This epidural space should produce a white line. White line, why? Because there is no bone, and of course bone is there, but less amount, and it is due to the air, not air. I mean, that bony structure is not there, so this area, epidural space, will become more whitish. As already I have shown you in the SI joint overlapped area. So that white color you will see. Okay. So this is the SI joint. Again, AP view. S1 transforaminal. Okay. This one was S1 transforaminal. Now I will go for last procedure, that is caudal epidural. Shoot. So for caudal epidural, here it is very clean. So we can understand from a very big distance also that this is the caudal canal.
The volume in the S1 you will get.
Oh, S1, true S1. So S1 foramen mainly 3 to 5 ml. 3 to 5 ml. Mainly it is for radicular pain only. We go for radicular pain, sometimes for only S1 radicular pain, and sometimes we remain a bit confused that whether it is L5 radiculopathy also is there or not. So then we will go a bit, we'll give a bit more. Otherwise, if your target is only one particularly S1, then 3 ml is sufficient, 2.5 or 3 ml. And if it is 2, then we will go for 5 ml. That's it. But remember, it is not for opposite side, same side. So here caudal canal is very much clean. We can see but in a normal patient, you may not, where there is so many tissue, fat, everything is there, you may not see so nicely, but still a caudal canal can be seen. So in AP view, what is our aim? Our aim is to see the midline, and needle tip should be always in the midline. That is our aim in the AP view, in a true AP view. Okay, and we will start, say it is the caudal canal area, so we will start nearly 4-5 centimeter down, at least 3 centimeter down. Okay, and then we will go in a nearly 45-degree direction. But of course, since we are using fluoroscopy, we will not decide before the procedure. During the procedure, we will decide how much angulation is needed. So here, as I told, first we will go for a shoot. So we can see that we are in the midline. Okay, so now I show you, let me find the tip of the caudal canal. Shoot. Okay, so this is the tip of the caudal canal, and I will make it straight. Okay, shoot. Okay, so this is a straight line, and this is the tip of caudal canal. So I will use I will start from nearly 3 centimeter below the caudal canal. Okay, shoot. So from here, my main aim is just the direction, just to choose the direction here. Okay, shoot. I don't know how much depth I am going. I may be completely wrong or maybe right also. So this should, so this much. I don't know that how much depth I am going. Now I will go to the lateral direction. So it doesn't matter if I would have gone a bit right side or left side. Tip of the needle should be in the midline. So root. Okay, so see, I am going in a very wrong direction. It is not the correct direction. So from this, I will go in a right angulation, but otherwise direction of the needle has to be the same. Should. So I think that I am in the right place, but whether I am in the midline or not, let's see in the AP view again. It is the same way we will proceed. Otherwise, your needle may be in one-sided. Okay, so I am just going in the same midline. Okay, shoot. So I will go a bit more. Shoot. Okay, lateral. So in lateral view, what I will see, I should not go beyond the lower part of S2. আরে উঠাও পড়ে ওদিকে নেই আরো okay, so you can see clearly which one is S1 and which one is S2. So this one is S1, this one is S2, and this one is S3, S4, and 5 is there. So lower end of S2, say this much only is sufficient. Should. Okay, so this much is sufficient. So this is about caudal epidural, huh? And okay, it's done. So any question? Any question or anything you have not understood?
So what volume we give in caudal?
So volume, the volume of sacrum caudal
Yes.
canal is 30 ml, but we don't need. We are not providing anesthesia. So we will give from the tip, say it is in the lower part of S2. So segment by segment, if we count, 2.5 ml gives to one segment. So nearly say we want 10 ml, 12 ml, or that much is sufficient to cover all the lower lumbar area. Say lower from L3, 4, 5, S1. That's it.
So is there any role of adhesiolysis? Because some people inject D5 the caudal.
Which one? Which one?
Adhesiolysis. Can we give a D5 injection in the caudal? 20, 30
That's
ml?
what that's it. I was saying that we had earlier did adhesiolysis with epiduroscope, but adhesiolysis is nowadays not very popular nowadays. Nobody does that because it doesn't. After doing lot of things, adhesiolysis and all everything, patient gets relief for 6 months. So what is the use? So because adhesion, you can take out adhesion, but adhesion again comes back. So it is not a very
Can
popular thing. Popular thing is
can
spinal
we
cord
combine
stimulation.
caudal with transforaminal block?
That's this already I answered that
This is
caudal
not
or transforaminal, where we are going, the tip is going in the epidural space. So why should I
okay.
give both the things in the same space in different windows? There is no meaning of entering caudal when others are not applicable. Hmm.
These are daycare procedures or patient has to be admitted overnight.
Sounds
All these procedures are daycare procedures.
all daycares, and within 2 hours patient will be discharged. You have
But
to
patient can have numbness due to local anesthetic injection.
local anesthetic, as I told you, that local anesthetic is for our satisfaction. We want to know that we have targeted the right pain generator. Okay, just diagnostic key. Otherwise, it doesn't have any long-term effect. So we do not give any bupivacaine, ropivacaine type of thing. We give simple 1% Zylocard. So our patient do not get motor paralysis also. They only give sensory relief. So after 1 hour, they are completely, they can go. No problem. Okay.
Sir,
Yeah.
sir, can we puncture dura in S1 root block, S1 transforaminal?
Theoretically, we can puncture, but problem is you can see the picture of dura. It is conical, so usually we do not puncture. Through S1, if you go through another foramen also, then also you do not puncture, because at that area dural sac has become much thinner and in the midline, and our needle doesn't puncture through the midline, but theoretically you can through. True.
So what
Okay,
do you do
sir.
if you puncture the dura?
You will not proceed with the procedure. Contrast you will give contrast, as radiologists are always doing myelography. So you will also see a myelogram, and then you will not do the procedure. That's it. Even you can do the procedure also. When you take it out and reposition, you can do, no problem. Of course, if you are puncturing with a small needle like spinal needle and all, and if you are puncturing with caudal, then better to avoid. We do not want
But we
any.
cannot see the repeat contrast like image. That image we are not able to see. No? For how much time it will take to wash out of the?
What?
We will not be able to see the contrast image if we puncture the CSF.
Why
If
not?
we reposition the needle.
No. After you have put the needle, you have given contrast. Then only you have understood that your needle has punctured the dura. You are in a subarachnoid space. Then only you will understand. Otherwise, how will you understand?
No, if the dura is whole thing goes black, then we push back, take back the needle, and then again we inject contrast, then we will not be able to differentiate that still we are in the epidural space or subarachnoid
Yeah,
space.
yes. If you do not understand, then do not proceed with the procedure. But this thing has not happened with me, so I don't know. But theoretically, if I can understand that epidural spread is completely different and subarachnoid spread is completely different. One is in the midline. It is guarded by the pedicles. It doesn't go outside the pedicles. But if it is in the epidural space, so it will come out through the foramens, and it is like a fir tree appearance. All drugs are coming out. So you will understand still that. Okay. Okay. Any other question?
Yes, sir. I have one question.
Please. Please
What
tell me.
about the usual epidural that we used to do for pain relief? We don't do it anymore. It has to be either transforaminal or caudal or the other techniques. We don't do anymore the normal epidural.
No. There is no point. As I told you, that if you do a normal epidural interlaminar, then nobody is going to say that you have done a great wrong thing. But this is also understood that you are wasting the drug. Because drug will not act in the posterior side of the epidural space. It is going to act in the anterior side of the epidural space. If there is a disc prolapse, radiculopathy, or if it is a radiculopathy, there is no question of epidural in this way. And if it is only, say, if you want to, it is a non-specific back pain or lumbar canal stenosis, and then you want to go for caudal epidural, then you may give interlaminar epidural also. But as I said, drug is wasted. Every area is not filled with the drug. Interlaminar epidural spread is a bit different. It is in the posterior side. It doesn't go anteriorly much in a better way. So nowadays there is no indication. For pain procedures, there is no indication of interlaminar epidural.
Thank you. One last question. For the needles, is it like a TOE or it's a complete? Because how do you know that you are not, you enter easily with the needle? Is the tip different or it's a normal needle?
Which one? Caudal?
Yes.
Yes. Caudal is epidural needle. What we are using. What we are always
TOE.
using under anesthesia, what we are using, that needle is for caudal epidural. It is the same needle. And for transforaminal and all other techniques, all are through S1 transforaminal or last day what we showed transforaminal. Those are spinal needle, Quincke spinal needle.
Okay, thank you.
What is the size of the epidural needle that can be used, sir? Please.
Same. Caudal epidural is same only, whatever we are using in anesthesia, no? So 18 gauge or 16 gauge, but then why to go in 16 gauge? 18 gauge is sufficient. 18 gauge we are using, same.
So do you put catheter with caudal?
No. You have to understand the aim. Long-term pain relief. We do not want to give pain relief immediately. There is no need, because we want to discharge the patient. Let the patient go with pain to his home, because already
No, sir.
I
Means for the higher levels, if the drug is not reaching to L4-5, do you guide it with catheter?
it can be done, but what is the it is not needed. I will go under the L5 pedicle and then I will reach. So catheter is not needed. Yes, there is a procedure for neuroplasty where we put the catheter through the foramen and if 3% saline, but nowadays these things are not done that much. So catheter use not needed.
The steroid dose is 80 mg for caudal.
Somebody is talking so much.
So steroid dose is 80 mg for this thing, caudal.
No, steroid
Steroid, what's the
80,
dose of steroid?
80 mg. Just a minute. Uh, 80 mg highest in one session. Though it is not a very hard and fast, if you give a bit more also, sometime you can give, but usually we maintain that we do not go above 80 mg because steroid has a limit of its use. You cannot repeat frequently. Okay, so in one session it is 80 mg, but then if you are targeting one root, then you go only 20 mg. If you are targeting one joint, then you go for only 40 mg, like that. Even for median branch block and all, you can go 10 mg per joint, like that. Okay. Any other question?
Sir, can I ask?
Yeah, tell me.
Sir, in caudal epidural in lateral view, where does our needle tip should be? To the anterior sacral plate or
No,
posterior
yeah,
sacral plate?
both plates. Okay, posterior sacral plate and anterior sacral plate. Between them, anterior sacral plate means it is the posterior wall of the sacral vertebral body. That is the anterior plate. And posterior plate means it is the fused laminas. Okay, from lower level, upper level, all laminas have fused. So ultimately, it is the similar to lumbar spine only. So in between both the plates, that is the area where your tip should come. It is the same place where caudal epidural needle tip should come. It is the same place.
So is there a more chance if I put the needle in the anterior near the anterior plate and the chance of going the dye to the anterior epidural space upwards?
No, it doesn't happen. You are not injecting from downward to upward. No, you are coming from posterior side, and usually it goes I mean, in this epidural space. There is no need for the S1 transforaminal. There is no need for so much manipulation. If you inject there, the drug will go in the anterior epidural space. Of course, in the posterior also, but mainly in the anterior epidural space it goes. Both sides. You don't have to
Okay, sir.
manipulate.
Thank you.
Directly goes.
Okay. Okay, sir.
Okay. So, okay. Good night for today. You all see the recording, and as I told you that these procedures are not for memorizing. It is the concept you have to understand that why we are making the fluoroscope tilting towards head or towards leg. So those things, I have some free videos in the Asian Pain Academy YouTube channel also. In SI on SI joint also it is there. So you please see. Okay. Thank you. Good night.